And now I'd like to welcome James Kashanian. Dr. James Kashanian is the Director of Male and Sexual Health and Assistant Professor in Urology and Reproductive Medicine at Cornell Medicine. He did his fellowship at Northwestern, and his clinical and research interests focus on erectile dysfunction, penile prosthetic surgery, men's health, and male infertility. It is my pleasure to welcome Dr. James Kashanian. I hope I said that right.
Yeah, thank you for that kind introduction. I'd like to thank the organizers of the meeting also for inviting me. We are going to switch gears a little bit to male infertility, so hopefully everyone doesn't get up and walk out. So we're going to be talking about fertility preservation in the Klinefelter Syndrome patient. These are my disclosures. They're not relevant to this talk. So as an overview, we're going to talk about Klinefelter Syndrome background, signs and symptoms associated with Klinefelter Syndrome, fertility treatment in these patients, and effect of testosterone replacement on fertility in this patient population. As we go through the slides in the talk, we just want to keep this kind of index patient in mind. This is a patient that I saw a few weeks ago. He's a 15-year-old Klinefelter Syndrome male who presented with his parents for a fertility evaluation. He had initially been diagnosed at the age of 13 years old with 47XXY, which is a classic Klinefelter's. He presented with a history of delayed puberty, had struggled lifelong with learning difficulty, and had atrophic testicles. Interestingly enough, his testosterone level was normal at 382, but his FSH level was about 6 times the upper limit of normal at 42. So what are things that we kind of want to think about as we are kind of walking into the room to talk to this patient, to talk to this family? I mean, I think the top of the list is, when do we discuss fertility preservation and what are the options? When do we first do a semen analysis? How often do we do a semen analysis? And when is surgery for testicular sperm extraction indicated? And then beyond that, when do we talk about and when do we check testosterone and gonadotropin levels? How often do we do that? If testosterone level is low, when do we initiate testosterone replacement? And if we're initiating testosterone replacement, what type of testosterone replacement do we start? And what effect might that have on that patient's future fertility? So just as an introduction, Klinefelter syndrome classically presents with an extra X chromosome, 47XXY. It was first described in 1942, but currently has a prevalence about 1 in 5 to 600 live male births. So it's not uncommon at all. Klinefelter syndrome patients classically present in late puberty, early adulthood with tall stature, gynecomastia, and small testes. And historically, only about 10% of males were diagnosed before puberty. But currently, with prenatal genetic testing, a lot of these individuals are diagnosed in utero around the second trimester. It is the most common cause of obstructive azoospermia, or genetic cause of obstructive azoospermia in men. And because the classic signs of Klinefelter syndrome are often not present, men are commonly diagnosed through their course of fertility evaluation, although, again, this is somewhat changed. Hormones generally are patterned as hypergonadotropic hypogonadism. FSH levels are usually in excess of 30. Testosterone levels are usually in the low range, below 300. But a moderately elevated FSH or a normal testosterone level does not rule out the diagnosis of Klinefelter syndrome. And importantly, these men with low testosterone manifest with various clinical symptoms, and lifelong replacement may be necessary as early as adolescence or early adulthood. And while this may confer benefits like prevention of osteoporosis, prevention of obesity, decrease in metabolic syndrome, the effects of exogenous testosterone on fertility needs critical consideration and really should be not taken lightly. So what are signs and symptoms? Well, most commonly hypergonadotropic hypogonadism. They present with small, firm testes. They'll have azoospermia most of the time, which means no sperm in the ejaculate. They'll have decreased virilization, especially when compared to their siblings or first-degree male relatives. They will have less body hair, less facial hair. They may have gynecomastia, and there are some neurocognitive defects that are associated with Klinefelter syndrome. Those are the more common signs and symptoms, but there are some less well-known signs and symptoms of Klinefelter syndrome that we really should be aware of. Increased risk of metabolic syndrome, osteopenia, type 2 diabetes. There is an increased risk of cryptorganism in these patients, and there's an increased risk of cancers in these patients. So the adolescent Klinefelter's patient has an increased risk of mediastinal tumors, and adult Klinefelter's males have an increased risk of breast cancer. And this is important, all these are important because these patients shouldn't just be followed as adolescents, but they should be followed through their adulthood and monitored not only by the endocrinologist or the reproductive urologist, but also closely by the primary care physician and potentially the cardiologist as well. Cognitive behavioral deficits in men with Klinefelter syndrome is also an important aspect to think about. Approximately 80 to 90% of KS males have this classic genotype of 47XXY, but some will be mosaic and some will have higher grades of aneuploidy. And patients with mosaicism usually present with milder phenotypes, while those with higher grade aneuploidies have more severe phenotypes, which usually result in language and speech disabilities. And studies have shown about a decrease in the IQ score about 15 to 16 with each extra X chromosome. Here you can see a table of signs and symptoms of Klinefelter syndrome attributed to either a supernumerary X chromosome, a testosterone deficiency, or both. And you can see that these things can be present before puberty, as you go through puberty, or in adulthood as well, and they can rear during different times of life. So why is Klinefelter syndrome so important to me, near and dear to me? Well, because about 95 to 99% of men with Klinefelter syndrome will be infertile. And actually, prior to 1993, when ICSI was first invented, these patients were considered untreatable. And now, even if these Klinefelter's men are azospermic, microdissection testicular sperm extraction can be successful in retrieving sperm in up to 2/3 of men. And this is done by finding small pockets in the testicle where have dilated seminiferous tubules which may have mature sperm. And this retrieved sperm, because of the advent of IVF-ICSI, can now result in pregnancy without the risk of transmitting this sex chromosome abnormality to offspring. So what's the kind of data behind this? What's the science behind this? So poor sperm production is hypothesized to be due predominantly to 47XXY spermatogonial stem cells. This essentially leads to germ cell loss, seminiferous tubule hyalinization throughout the tubules, but there are some rare pockets of sperm production with normal spermatogonial stem cells that lead to mature sperm that we can find during a testicular sperm extraction. There are two hypotheses that explain potentially why there is present a mature sperm in these men. One is the XXY spermatogonial stem cells may be capable of completing meiosis, producing functional sperm, or secondarily, normal XY spermatogonial stem cells may be present as a result of mitotic errors during expansion of the cell population, leading to normal spermatogonial stem cells leading to mature sperm. And with the improvement in microtesticular sperm extraction procedure, with the improvement in ICSI, live birth rates are as high as 53% in this patient population, where 30 years ago, they were rendered completely infertile and untreatable. But it's not just about the patient, it's really about kind of the family and the family dynamic. The diagnosis of Klinefelter syndrome, especially for an adolescent patient, is challenging for both the patient, the family, the parents, also the physician. There are some difficult discussions that we need to have. We need to discuss the desire for future fertility, the need to do a semen analysis, whether we do it up front or we delay doing a semen analysis, and how often we do the semen analysis. The discussion of sexual dysfunction, do you have that with the individual by himself? Do you have that with the parents present? And then the discussion of hormone replacement, when should that be initiated, and what are the implications of that? And this often occurs in an age when full maturation or understanding of sexuality really isn't reached. I mean, we're talking about boys in their young adults and their early teenage years, where the farthest thing from their mind is having kids in the future or having to do a semen analysis. So those are the kind of the considerations on the family end, but on the practitioner's end, when do we do a semen analysis? The ideal time frame really is not clearly understood. Some clinicians may recommend multiple semen analyses to be done in hopes of finding some sperm production along the course, but is this supported by the literature? And in early age, this really has psychosocial impact and stress on the adolescent and family. Practitioners are also faced with the tough decision of when to initiate testosterone therapy and simultaneously considering the fertility implications of that testosterone replacement. And then lastly, the optimal time for surgical intervention is heavily debated, which we'll get into in a few slides, which is, I think, why I was probably invited to give this talk. But in the ideal clinical situation, we can give, these males can give a semen sample, sperm is found, they can cryopreserve sperm, and then they can kind of go on with their life. But that's not the reality, and the overwhelming majority of these men will not be able to cryopreserve ejaculated sperm. And there are many that believe, because of progressive degeneration of the testicle, that early microtesticular sperm extraction should be offered in adolescence as soon as spermatogenesis is thought to occur, around Tanner stage, maybe 3 or 4. So this is a bit of a busy slide, but this is an algorithm put out by the University of Miami. And basically, in a nutshell, it recommends doing a semen analysis yearly until the adolescent has reached Tanner stage 5, cryopreserving sperm if present, and if sperm is absent, either offering a testicular sperm extraction up front or deferring it until adulthood. It's kind of vague recommendations, but this is kind of where we are at this stage. And I'm hoping to show in the next few slides, where we are with the data on semen analyses and where we are on the data for testicular sperm extractions. So we actually, in combination with the University of Miami, published a retrospective review on adolescent Klinefelter syndrome males aged 12 to 19 years old, looking at semen parameters. Out of 116 males in our 2 facilities, 48 of those men were able to give a semen sample, and 92% of those men were deemed to be azospermic on the initial semen analysis. 8% of those men had rare sperm in the ejaculate, and the difference in age, the men who had sperm found in the ejaculate were slightly older, but not statistically significantly older than the boys or the men that had no sperm in their ejaculate. Looking a little bit deeper, amongst the 4 patients who had rare sperm in the ejaculate, only one of those patients was actually noted to have rare motile sperm, while the rest had non-motile sperm. And then when we looked further at the 48 patients who initially gave a semen sample, 35% of those men gave a follow-up semen sample 1 year later, and they were basically found to have similar findings of azospermia, or rare non-motile sperm. So where do we think we are with semen analysis and Klinefelter syndrome? Well, in our study, only about 8.3% of the adolescent Klinefelter syndrome patients had rare sperm in the ejaculate, but most of these samples contained non-motile sperm and were unable to be cryopreserved. Additionally, the repeat semen analyses were not very useful, showed similar to the initial findings, and also were not able to be cryopreserved. These findings are consistent with other studies in the literature where Okada revealed azospermia in 99% of patients aged 22 to 24 years old, and Franco demonstrated 92% of patients being azospermic between 18 and 45 years old. And Franek, looking at kind of all the studies in aggregate, identifying only 2% of these males being able to adequately cryopreserve sperm. So I think based on our findings, our study, and the relevant published literature, there doesn't appear to be a utility for performing multiple successive semen analyses in Klinefelter syndrome patients in adolescents or young adults. So our recommendation, at least our institution, is we have them do 2 or 3 semen analyses when they are comfortable doing so. And then if they're unable to do so, we don't usually recommend for doing subsequent semen analyses, although if they like to, we can obviously offer it. The question still remains, though, in the majority of these patients who are unable to cryopreserve sperm via ejaculation, what options do we have for them? And really the next option is surgical sperm retrieval. The question remains, what is the optimal timing for the sperm retrieval, and how does testosterone use affect sperm retrieval in these Klinefelter syndrome males? So Why has the optimal time been so controversial? Well, I think it's because the data is kind of all over the place. If you look at sperm retrieval rates for adolescents, they range anywhere from 0 to 70%. If you look at sperm retrieval rates in adults, they range anywhere from 20 to 72%, so pretty similar. And although sperm retrieval in adolescent Klinefelter syndrome males is performed, the optimal age at which surgery should be performed is not known. And there's very few predictors of sperm retrieval in Klinefelter syndrome, and none of these predictors are definitive. And there's also been conversation, over the years where the pediatric endocrinology community has recommended, fertility preservation in this population, but with the knowledge or the absence of knowledge of knowing if it's really beneficial. So diving a little bit deeper, what is the real controversy? So those that are in favor of early microtesting during the adolescent age argue that puberty and the rise in LH and FSH may lead to progressive decline in germ cells. Testicular volume in Klinefelter syndrome boys will increase to as much as 6 cc's, but will decline over the years to 2 to 4 cc's. So the question is, are we losing the opportunity where fertility might be optimal in larger volume testes? The argument also is if we are initiating testosterone treatment, will this further decrease sperm retrieval success rates? And there are some experts that believe there is a window of optimal fertility preservation between the ages of 16 and 18 years old. Conversely, the argument for delaying microtesting till adulthood or till interest in paternity argue that early microtesting is aggressive and patients become profoundly hypogonadal in the recovery phase. Adult microtesting success rates are similar to adolescent success rates, around 50%. And adolescents are also not at the age of consent. And the parents are essentially making a decision for these patients, even if you're getting, adolescent assent. So we really want to dive deeper. We wanted to look at what the data shows. We are a center of excellence for Klinefelter syndrome patients. So this is a paper recently published in the Journal of Urology. We looked at age, sperm retrieval rates, and histology pattern in men with Klinefelter syndrome. I should say, in men with Klinefelter syndrome undergoing microtesticular sperm extraction. This was a retrospective review over a 25-year period. Our primary outcome was looking at testis histology and sperm retrieval rates, and we excluded men who were undergoing a repeat sperm extraction or who had no histologic data on file. We subdivided these men based on age ranges. So we subdivided them into adolescents and adult age ranges, and we further subdivided adults into decades, 20 to 29, 30 to 39, and greater than 40 years old. And of 270 patients that we included in the study, 59 of these were under 20 years old, 8 of which were over 40 years old. What we found was the BMI for the cohorts did vary with age, but the adult BMIs were relatively the same. The predominance of the cohort were white males. Median testis size in the adolescent was about 3 cc's, and the adult was about 1.5 to 2 cc's. And testis size as well as hormone levels were not significantly different between the adult age groups. And what we found was actually surprising to us and pretty interesting. We found that sperm retrieval rates were highest in the age group of 20 and 29 years old. Overall, the successful sperm retrieval rate was 54% in the overall cohort, but men who were 20 to 29 years old had a 71% chance of having successful sperm retrieval in this group, compared to 52% in men under 20 years old and much lower, 12.5% in men older than 40 years old. What we also found was a slight decrease in germ cell containing histology as men aged. This did not correlate with sperm retrieval rates, although until you got to the men who were 40 years and older, where it did directly correlate to sperm retrieval rates. And those men at 40 years and older didn't have any germ cells found on their histopathology. After multivariate analysis, the only two things that really predicted success in sperm retrieval in these Klinefelter syndrome men was adult age being 20 to 29 years old and having hypospermatogenesis on pathology. So take-home message for microtesting: while early decreased reproductive potential may result in the absence of sperm and ejaculate, successful surgical sperm retrieval rates have been shown to be as high as 70% in adults. Nahata showed similar 50% sperm retrieval rates aged 12 to 25 years old. Okada, also 50% surgical retrieval rates, with highest rates in men that were younger than 35 years old. So in our institution, we don't routinely recommend adolescent microtesting. Now, I hope this isn't going to stop me from getting invited next year, because technically we're not doing fertility preservation in these men. But there are some caveats to this. I think obviously patients who are undergoing gonatotoxic therapy, they should be offered treatment up front, no matter what age. And then the other caveat to this is really those men or those adolescents who are being offered testosterone replacement. And we believe that there is a difference between the effects of short-acting testosterone replacement and long-acting testosterone replacement. What we consider short-acting testosterone replacement include things like gels, nasal sprays, oral formulations, and long-acting being injections or pellets. The reason why we think there's a difference because long-acting testosterone replacement formulations are known to suppress sperm production even in fertile men. Up to 90% of men on long-acting testosterone replacement will be azospermic, and even the WHO is looking at long-acting testosterone replacement as a male contraception. The question is, what happens with adolescents who are placed on testosterone replacement? Well, Dr. Mehta's group published this a few years back, looking at the safety and efficacy of testosterone replacement therapy in adolescents with Klinefelter syndrome. And what they found was placing adolescents on a testosterone gel did what it needed to do. It increased testosterone levels on average from 240 to 650, but did not significantly impact LH and FSH levels. These levels remained elevated as would be expected through testosterone replacement, thereby signifying that it's probably not affecting the HPG axis and likely not affecting fertility long term. We went back and looked at our data as well. Now, this is unpublished data, but we have presented this at a conference, and it is submitted for publication. So we looked at the use of exogenous testosterone in our patient population. And what we found is those on long-acting testosterone replacement had a much lower, in our cohort, those who were within 6 months on long-acting testosterone replacement had no sperm retrieval success. Those who were on short-acting had a higher success rate of 40% compared to those who had been off of it for greater than a year. So in conclusion, I think given all the data that we have, Klinefelter syndrome is a common genetic condition in men, and clinicians should be aware of the presenting signs and symptoms. Aggressive efforts at fertility preservation for adolescent Klinefelter syndrome males, in our opinion, is not warranted. It appears to be safe to wait until the patient can provide his own consent and is ready for fatherhood, understanding that at some point, closer to 40 years old or older, there is a decrease in sperm retrieval rates. Our recommendation is to do a sperm retrieval in men in their 20s and 30s. And if testosterone is needed, we do recommend short-acting formulations and or the use of aromatase inhibitors or HCG. If long-acting testosterone replacement needs to be used in these men, then we will offer early microtesting and sperm cryopreservation. I just want to give a small plug to our consortium at Cornell. We have significant collaboration on our side from the urologists, the pediatricians, the geneticists, the psychiatrists, and the chronologist. And we all work as a large group trying to help kind of this patient population navigate the difficulties that come about. And with that said, I'd like to thank you for your time, and I'll take any questions.
So thanks, James. That was terrific. You were describing your thinking about why in some cases there may be spermatogenesis, and you talked largely about the genotype in the germ cells. But if you look at a histology of a Klinefelter's testis, there are what appears to be somatic morphology changes like thickened basement membrane or hyalinized basement membrane. So I'm wondering whether the phenotype is all about the germ cell genotype or whether there might actually be somatic issues as well.
It's an excellent question. I wish I had the answer to that question. I don't think we have enough information at this point to know. I think there are small I think what the data shows is there are small pockets of genetically normal tubules that are creating these normal spermatogonial stem cells that then go on to then go on to create normal mature sperm cells. I guess the question we have is, why is it occurring in only a certain proportion of men and not in all the men?
And kind of related, and you may or may not know this, but if you looked at a section through a testis of a Klinefelter's man and found a tubule with spermatogenesis, does it also have a less thickened basement membrane of the tubules?
It does.
Okay.
Yeah, it does. And just grossly appearing, you can grossly see the difference in the tubules. And that's really how we kind of target it during the surgery under high magnification. We look at grossly normal appearing tubules and target those for our sites.
Thank you very much for the nice presentation. Do you believe in, if the testosterone is low, in resetting the HPO axis and supplementing the man with gonadotropins prior to testicular sperm retrieval?
I think your question was, do I believe in resetting the HPG axis?
Correct.
So there is some preliminary data looking at that. I don't think we have large enough studies to look at resetting the HPG axis and reinitiating spermatogenesis. It's kind of a question I've always had, but I don't think we need large randomized controlled trials really to tell the difference and seeing if that's appropriate.
Thank you.
I wonder, could it be that the men of adolescent age who don't go through puberty, and I think that's a minority of the Klinefelter's cases, could it be that they really have to be on testosterone so they can have a normal life, but could they be the ones that aren't going to have sperm either, so that you're not hurting them with long-acting? I'm just asking, I don't know.
So there is a study that was published out of Cornell about 10 years ago or so that looked at actually testosterone levels and the correlation between success rates in testicular sperm extraction in Klinefelter's men. What they found was that although the baseline testosterone levels didn't correlate to successful sperm retrieval, those who were initiated on some sort of testosterone replacement, like an aromatase inhibitor, or HCG, or Clomid, those who responded better had higher retrieval rates than those who didn't respond. So I think that innately there is a functioning of it that represents some functioning of the testicle where certain men do have higher functioning testicles that will have a higher sperm retrieval rate. So I do agree. I think there are some men who do need testosterone replacement more so than others, and those men have probably are starting with lower testosterone levels and probably will have lower retrieval rates.
With those men who need testosterone, would they be adolescents that you might be willing to do a TESA on just because you don't know?
I think I think currently our kind of algorithm is if they need testosterone, we'd prefer them to be on a gel or a nasal spray or an oral formulation, but usually gels. But oftentimes those gels don't get levels high enough, especially if they're severely hypogonadal. So they might have to transition over to a long-acting testosterone formulation for long term. So those are the men that I think should have early intervention. We would have them off testosterone replacement altogether. We'd try to optimize their endogenous production of testosterone for a period of 3 to 6 months. Then we'd move on to the testicular sperm extraction, and immediately after, we would transition them over to a long-acting testosterone replacement.
Thank you so much. That was such a great talk.